Hello, everyone. I want to welcome you to today's webinar, let you know you're on the right place. Going to allow about another minute for everyone to file in and get settled. We'll get going in about a minute from now. Thank you. Once again, I want to welcome everyone to today's webinar. Going to allow about another 30 seconds for everyone to get ready and get filed and set. So thank you. We'll get going in about 30 seconds. Okay, an official hello, everyone, and welcome to today's Safety and Health Magazine webcast, Bloodborne Pathogens Terminology, Exposing the Regulation One Term at a Time, sponsored by J.J. Keller. My name is Kevin Drewley. I'm an associate editor with Safety and Health Magazine and will be moderating today's session. Thanks for joining us. We hope you all are doing well. In a few minutes, we'll start a presentation, but first, let's review some preliminary items. The views of today's speakers and organizations are their own and may not necessarily reflect those of the National Safety Council or Safety and Health Magazine. Any mention of a commercial enterprise, product, or publication does not necessarily mean the council or magazine endorses those items. At the end of today's webcast, we'll conduct a question and answer session. To ask a question, simply click the Q&A button at the bottom of your screen, type your question, and click the send button. Feel free to ask your question at any time during the presentation. You don't have to wait for the question and answer session to begin. We'll try to answer as many questions as possible, but because of the large number of participants today, we might not get to every question. And any unanswered questions will be forwarded along to today's speakers. At the end of the webcast, you'll be asked to complete a brief evaluation survey, and we'll let you know more about that after the presentation. This webcast will be archived, so you can access it after today's live event. To view this webcast and all of our past webcasts, please visit safetyandhealthmagazine.com/events. With that, let's go ahead and get started. Our speakers today are Tricia Hodkovich and Rachel Krubsack. Tricia has been an EHS editor at J.J. Keller since 1994. She provides content for manuals, handbooks, videos, signs, training materials, and online solutions. Her duties include writing a newsletter covering the latest news from OSHA, the Environmental Protection Agency, and the Department of Transportation. Rachel is an EHS editor at J.J. Keller whose duties include writing a monthly newsletter on OSHA safety training. Her topics of expertise include hearing conservation, training requirements, bloodborne pathogens, emergency action plans, and hazard communication. Again, we thank you all for tuning into this presentation today. Tricia, whenever you're ready, go ahead and take it away.
All right. Thank you, Kevin, and welcome, everyone. Today's webcast is sponsored by J.J. Keller Training. J.J. Keller Training Solutions cover a broad range of topics and are available in a variety of formats: training on demand, DVD, streaming video, and video books, all to help you meet your needs. And backed by regulatory experts and using the latest techniques and technology, our training solutions give your employees the proper instruction they need. So on behalf of our sponsor, J.J. Keller Training, thanks for joining us today. All right, here we go. So the Bloodborne Pathogen Standard Act 1910.1030 defines 28 terms in its definition section. So the use of these words and phrases may make this regulation a challenge for employers. So today we will start with the definitions provision and turn to terminology related to some basic terms first. Then we'll talk about terms related to the topics you see here. And throughout the webcast, we define terms colored in blue. So watch those blue terms. And also, just a word of caution, some images will show what look like blood. So please chime in through the attendee chat feature. The chat feature can be viewed by everyone. Just be aware of that. Plus, we won't be searching the questions from the chat. Instead, the Q&A box comes to us directly. So please use the Q&A feature for your compliance questions to us. So narrowly, they don't get lost in the chat. We also plan to pose some poll questions that will pop up on your screen. All right, so before we get too far along, please use the attendee chat. How about tell us which word or phrase is the most confusing to you? Put another way, which one gives you a headache? So we have some bloodborne pathogens related words and phrases on the slide, but not all of them. So you feel free, enter your own custom answer if you want. And I know there are a lot of terms on this slide, but see if you can pick one or one of your own. And I do see some of the results rolling in. Here they go. All right, OPIM, a lot of those, of course, bloodborne pathogens. I'm glad you're here. We're going to talk about that all hour. Sharps injury log, exposure determination, occupational exposure, lots of OPIM. Yeah, parenteral, we don't use that term every day. Regulated waste. Interesting, some sort of consensus with OPIM, right? So it's not blood, it's OPIM. So what is that? There's a lot that goes under that umbrella. Fantastic participation. Rachel, you agree?
Yes, I see a lot of good results coming in, so that hopefully we can answer all these definitions today and help you make sense of them.
Right. Yeah, we are going to cover these terms and more today. So even though the chat will remain open, feel free to talk amongst yourself, but we will focus our attention on the compliance questions in the Q&A. So please submit your questions, compliance questions, or any confusion you have, especially with OPIM, instead of the chat, use that Q&A. So here we go. All right, so OSHA offers the definitions in paragraph B, and some of the definitions are explained in a directive, CPL 02-02-069 for clarification, and OSHA letters of interpretation and preambles may also help you. 1910.1030 applies to all exposure, occupational exposure, that is, to blood or other potentially infectious materials, OPIM, in general industry and shipyards. And Rachel will unpack some of these terms on this slide. Rachel.
All right, thanks, Tricia, and welcome everyone. I'm glad you could join us today. So the most basic term is blood, which means human blood components, and products made from human blood. Animal blood is not covered. OSHA gives examples of human blood components, and we've listed those here on the slide. Bloodborne pathogens are microorganisms present in human blood that can cause disease in exposed humans. While HBV and HIV are identified in the standard, the term includes any pathogenic microorganism that's present in human blood and can infect and cause disease in persons who are exposed to blood containing the pathogen. The CPL that we have listed here on the slide lists 15 diseases related to bloodborne pathogens. The regulation uses the phrase other potentially infectious materials, or OPIM, and only certain body fluids or tissues are considered OPIM as shown here. And we get questions about handling urine samples or cleaning up vomit. Scientists don't consider these fluids to be efficient modes of HBV or HIV transmission, so you won't see urine or vomit under the definition of OPIM. You also won't see feces, nasal secretions, sputum, sweat, or tears. Saliva, too, is not covered unless it's involved with dental procedures. However, if any body fluid is visibly contaminated with blood, it would be covered, even if the body fluid is not listed for OPIM. So if a urine sample is contaminated with blood, it's OPIM. If you cannot differentiate between body fluids, that's OPIM too. Back to Tricia.
All right, thank you, Rachel. So excellent. Exposure or exposed means a worker is subjected to a toxic substance or harmful physical agent. And so this includes biological agents, in this case, a bloodborne pathogen, in the course of employment through any route of entry, and includes past exposure and potential or accidental exposure. Even with protections, your workers might still have an exposure incident, which means a specific eye, mouth, or mucous membrane non-intact skin or parenteral contact with blood, or OPIM, that results from the performance of a worker's duties. Mucous membrane basically means the inside of your nose or mouth or in your eye. Blood or OPIM that spatters into your nose, mouth, or eye is considered an exposure incident. By non-intact skin, OSHA includes skin with dermatitis, hangnails, cuts, abrasions, chapping, and so on. Parenteral, right? We don't use that every day. That means piercing mucous membrane or the skin barrier, such as by needle sticks, cuts, or abrasions. This includes human bites that break the skin, such as that may be encountered by prison guards, police, or in emergency rooms or psychiatric wards. So 1910.1030 applies to occupational exposure. And now an exposure incident is actual contact only, but occupational exposure is reasonably anticipated contact with blood or OPIM. In addition to being reasonably anticipated, that contact must result from the performance of a worker's duties. You would not reasonably anticipate an office worker, to have contact with blood or OPIM. However, if you designate that office worker to perform first aid involving blood-related injuries of coworkers, now that worker does have occupational exposure. Job duties don't need to be healthcare related. Manufacturers, services, retailers, warehouses, and other industries may have covered workers. OSHA does not tell you what jobs or tasks are covered. So you have to make a determination whether your workers have occupational exposure by definition. The occupations that are listed on the slide may have occupational exposure, but not necessarily in all cases, and there may be others too. So Good Samaritans don't have occupational exposure. Assisting a coworker who's bleeding would not be occupational exposure unless the worker providing assistance is a member of a first aid team or is otherwise expected to render that assistance. Employee under the standard means an employee with occupational exposure. Full-time, part-time, temporary, or contracted, an employee is covered if he or she has occupational exposure. Today, we will just refer to employees as workers. The employer can be large or small, but 1910.1030 only protects general industry and shipyard workers. Now, I see that Keith did pose a question in the Q&A, where this is a general industry standard, how does this apply to construction sites and employees engaged in construction activities? Thank you, Keith. I'm going to address that right here and now. For construction, OSHA relies on the provisions that are listed on the slide to make sure that construction workers are protected. Remember, 1910.1030 is only general industry and shipyards. So we turn to these construction standards listed here on the slide for that industry. So first aiders at construction sites are expected to receive basic instruction in bloodborne pathogens hazards, as well as vaccination and follow-up in the event of an actual exposure incident. Appropriate personal protective equipment, waste containers, and signs and tags must be provided. And from here on out, unless I get another question, we will not touch on construction regulations today, at least for our slide. All right, so if the bloodborne pathogen standard applies at 1910.1030, you'll make an exposure determination. And this determination is based on the definition of occupational exposure without regard to personal protective clothing or equipment. You'll review job classifications at your site and make two lists. The first list includes job classifications in which all workers have occupational exposure, like operating room scrub nurses, right? So for these jobs, it's not necessary to list specific work tasks, just list the job. A second list will include those classifications in which only some workers have occupational exposure. For these cases, specific tasks and procedures causing occupational exposure must also be listed. So for example, perhaps only some of your custodians are assigned to the task of handling blood spills while others are not. You would list custodians in that second list and then list something like cleaning up blood spills under that job class. Rachel, back to you.
Okay, so once you know who has occupational exposure, you must train those workers under paragraph G. Information and training must be provided at the time of initial assignment to tasks with occupational exposure. It must be given at no cost to the worker during working hours and at least once a year after that. You'll need to do more training if you modify existing tasks or you add new tasks, and these changes or additions affect your workers' exposure. Annual retraining means at least once every 12 months, so within a period not exceeding 365 days. If the annual training cannot be completed by the anniversary, you should maintain a record saying why the training is delayed and when it will be done. OSHA says the information you provide must be appropriate for your trainees as far as education level, literacy, and language. Now, we should add that computer-based or video-based training are good training tools and that they can be used as part of an effective training program. Now, however, computer or video training alone is not sufficient because the standard requires trainees to have an opportunity to ask questions, and you must cover site-specific information like the location of the plan and how to report an exposure incident. The regulation lists 14 training elements. Two of the elements call for a general discussion of bloodborne diseases with specific emphasis on the epidemiology, symptoms, and modes of transmission of HBV and HIV. Epidemiology has to do with the prevalence and causes of a disease. Modes of transmission relate to the route in which a pathogen is spread. You must convey the idea that a number of bloodborne diseases other than HIV and HBV exist, such as hepatitis C. At the same time, you don't need to cover uncommon diseases unless it's appropriate, for example, for employees working in a research facility with a particular pathogen. Now, during training, as we said, it's critical that trainees have an opportunity to ask questions and receive answers where material is unfamiliar. Trainees must have direct access to a qualified trainer during training. But the trainer doesn't need to be in the room. Trainees can simply have direct access to a trainer by way of a phone hotline. Email is not considered direct access unless the trainer is available to answer emailed questions at the time the questions arise. Now, you'll need a trainer that's knowledgeable in the subjects covered by the 14 training elements. This trainer must also be familiar with how the training elements relate to your workplace. The standard does not define workplace, but under other OSHA standards, workplace means an establishment, job site, or project at one geographic location containing one or more work areas. You don't have to have a healthcare professional do the training, but if an OSHA inspector finds any training deficiencies, the inspector will look at the specialized courses, degrees, or work experience of your trainer. If there's no one qualified at your location, you may just need to send workers out to get trained or bring a trainer in.
All right, thank you, Rachel. All right, so how can you be sure that you are meeting all of OSHA's training requirements or that you're covering everything? Give your employees the knowledge to protect themselves from potential exposures with the J.J. Keller Bloodborne Pathogens Training Program. Whether you need to train on a few topics or many of them, J.J. Keller Training offers a full library of online training courses and pay-per-view streaming videos. And if you want access to free bloodborne pathogens training, free training in J.J. Keller Training and our bloodborne pathogens white paper, you can see that here, let us know by using the poll on your screen. And I don't want you to miss that white paper or that free training. So I'm going to give you some time to make your selection. And I'm going to take a question, Rachel. I saw earlier that Lucy asked a question about, let's see what it says. Do we need to post a sign on refrigerators if we store bloodborne pathogens inside? All right, so, okay, kind of a two-part answer there, I think. Lucy, first, you'll look at 1910 to 1030, of course. Paragraph G1, I'm going to direct you there. G1, that talks about how warning labels need to be posted on refrigerators and freezers that contain blood or OPIM. But of course, you asked about a biohazard sign, and I imagine that would warn about the biohazards that are in the refrigerator too. So signs like that are mandated, I would say, under a catch-all sign requirement. Totally different regulation, 1910.145. But it's kind of strange how OSHA words this. Only if failure to post that sign will lead to an accidental injury or property damage, then a sign or maybe something else like effective training or something would be required. So take a look, 1910.145, only if failure to post that sign will lead to an accidental injury or property damage would a sign like a danger sign or a caution sign be required. So you make that determination. But again, go back to that labeling requirement. So together, two parts, 1910 to 1030 G1 and 1910.145. That's where you're going to look. All right, we're going to move on to the next section. All right, the measures listed on this slide are intended to help prevent and control the spread of bloodborne pathogens. And so hepatitis B is a liver infection caused by the hepatitis B virus. And the best way to prevent hepatitis B is by getting vaccinated. The hepatitis B vaccine stimulates the worker's immune system to protect against the virus. And after the vaccine is given, the body makes antibodies that protect the worker against the virus. An antibody is a substance found in the blood that's produced in response to a virus invading the body, and these antibodies will fight off the infection if a worker is exposed to the hepatitis B virus in the future. And of course, the CDC says the hepatitis B vaccine is safe and effective. So vaccination must be at no cost to the worker. Among other things, there's no out-of-pocket expense to the worker. You may not permit the worker to use health insurance to pay for the vaccine unless you pay all the cost of the health insurance, and there are no deductibles, co-payments, or other expenses. You cannot have any reimbursement programs, and a waiver of liability from or for any harm caused by the vaccine is also prohibited. So the vaccine must be provided at a reasonable time and place. Medical procedures and evaluations must be convenient to the worker, normally offered during the worker's scheduled work hours. If travel is required, the employer must bear the cost. And next slide, the vaccine must be performed by or under the supervision of a licensed physician or other licensed healthcare professional. And that's a person whose legal permitted scope of practice allows the person to independently perform the vaccination. And finally, vaccinations need to follow the current recommendations of the U.S. Public Health Service. What does that mean? This simply means the CDC guidelines.
All right, so the vaccine is made available to occupationally exposed workers within 10 days of initial assignment and if they experience an exposure incident. But the worker has the option to decline the vaccination and follow-up programs. Medical informed consent forms are okay, but not required. Consent forms that require a worker to release test results to the employer, waive liability, or exaggerate the hazards of the vaccine violate the standard. First aid is often a collateral, not a primary duty of a worker. If you fail to provide the vaccination to these folks, OSHA can cite you but won't fine you. But the catch is, you have to address these types of first aiders specifically in your written plan. Track first aid events, train first aiders to report first aid events, and make the vaccine available within 24 hours of a first aid event, regardless if an exposure incident occurred or not. And this is spelled out in the CPL. Employers must ensure that workers who decline the vaccine sign a declination form. The language is set forth in Appendix A to the standard. Using a form which conveys the same information as Appendix A but with different words may be considered a de minimis violation. Any additions to the language should be made only to improve comprehension. The form must not add language that would discourage worker acceptance of the vaccine or add liability concerns. If you add information that requires the worker to provide confidential medical information, either on the declination form or on a separate form, a citation may be issued. A worker who signs the declination form may still request the vaccine at a later date, and you would have to provide it if the worker still has occupational exposure. The regulation says the employer shall not make participation in a pre-screening or antibody testing program a prerequisite for getting hepatitis vaccination. You can make antibody testing available at no cost to workers. If that antibody testing reveals that the worker is immune, you don't have to make the vaccination available. However, if a worker declines the pre-screening, then you must make the vaccination series available to the worker. You also cannot require a post-vaccination titer unless the CDC calls for it. CDC guidelines do in fact recommend this titer for healthcare personnel. For boosters, the regulation says if routine boosters are recommended by the U.S. Public Health Service at a future date, they must be made available. However, right now, the CDC does not recommend them, so OSHA does not require booster shots. The CDC is studying people vaccinated at birth to determine their duration of vaccine-induced immunity.
All right. There you go. All right. So the phrase a universal precaution means workers need to assume that all human blood and OPIM are infectious, and this does not matter who's known to have the diseases or not. And body substance isolation is a control method that defines all body fluids and substances as infectious. Standard precautions represent the minimum infection prevention measures that apply to all patient care, regardless of suspected or confirmed infection status of a patient in any setting where health care is delivered. Standard precautions include the practices listed on this slide. And BSI is an acceptable alternative to universal precautions, provided you adhere to all other provisions of 1910.1030. Similarly, standard precautions are more stringent than universal precautions and would be acceptable to OSHA. Back to Rachel. I think we have a poll here.
Yes, we do. Thanks, Tricia. So now at this point, as Tricia said, we are going to take an interactive poll to see who's joining us today. So now that you've seen a lot of terms so far, tell us, how would you rate your own knowledge of the bloodborne pathogens terms? So 1, you're aware of the terms. 2, you have a functional knowledge of bloodborne pathogens terms. 3, you have advanced knowledge of the terms. And 4, you're an expert in the terms. So rank yourself, and we'll share the results in just a bit. And this will go quickly. We have covered a lot of basic terms so far, along with terms related to exposure determination, training, vaccination, and universal precautions. There are more terms to come, but again, just rank yourself 1 to 4, with 4 being the highest knowledge of the terms. And I'll give you just a few more seconds here to lock in your answers. So please rank yourself at this time. Okay, I think we're ready to see what we have for results. We have 53% of you saying that you have a functional knowledge, 26% saying you have advanced knowledge. We got 15% saying that you are aware of the terms, and 6% of you rating yourself as 4 that you are experts in the terms. So that's great participation. Thank you. Hopefully we can add more terms to your knowledge here. So let's move on to a sharp. A sharp is an object that can penetrate the skin, including, but not limited to, the items listed here. So box cutters, razor blades, and knives are sharps. So sharps are not limited just to needle sticks. Engineering controls reduce worker exposure, either by removing or isolating the hazard, or isolating the worker from the exposure. A commonly recognized engineering control is a sharps disposal container for contaminated needles or other sharp instruments. Sharps with engineered sharps injury protections means a non-needle sharp or a needle device with a built-in safety feature. Needleless systems do not use needles, as the term implies. Proper work practice controls alter the way in which a task is performed. One work practice is having workers wash their hands when they remove gloves, and as soon as possible after their skin contacts any blood or OPIM. Also, if you have equipment that gets contaminated, You must examine it prior to shipping and, if necessary, decontaminate it unless you can show that this is not feasible. Because so many medical professionals have had needle stick incidents, OSHA frowns on a number of things when it comes to needles, like recapping and so on. And immediate disposal of sharps in the sharps container is an important practice.
All right, thank you, Rachel. So, hand washing facilities need three things: an adequate supply of running potable water, soap, and single-use towels or air dryers. Potable water. I listened to a dictionary pronunciation of that. Potable water, I love that word, means water that meets drinking water standards. And hand washing facilities must be readily accessible to workers. And that's because hand washing must be performed as soon as feasible to adequately flush that contaminated material from the skin. All right, antiseptic hand cleansers in conjunction with a clean cloth or paper towels or antiseptic towelettes are examples of acceptable alternatives to soap and running water. But these alternatives are only acceptable at sites where it is infeasible to provide soap and running water, such as at a crime scene, a traffic accident, or fire scene. So when alternatives are used, workers must wash with soap and running water as soon as feasible. Personal protective equipment is specialized clothing or equipment worn by a worker for hazard protection. General work clothes are typically not considered PPE. OSHA only considers PPE appropriate if it does not permit blood or OPIM to pass through to or reach work clothes, street clothes, undergarments, skin, eyes, the mouth, or other mucous membranes under normal conditions of use. And for the duration, the protective equipment will be used. When there's occupational exposure, you must provide PPE at no cost to the worker, and you want the PPE to fit, right? You know, if PPE does not fit correctly, it could cause tearing or inadvertently exposed skin, or something worse, maybe workers might refuse to wear it. So that PPE must fit. There are extraordinary exceptions to wearing PPE, but you'll want to carefully read these exceptions in the regulation. In general, PPE is expected to be used whenever occupational exposure may occur. Gloves of appropriate sizes must be made available. Gloves should be worn when it can be reasonably anticipated that the worker may have hand contact with blood, OPIM, mucous membranes, and or non-intact skin when handling or touching contaminated items, or when performing certain vascular access procedures. Disposable gloves are single-use gloves that must be replaced as soon as practical or as soon as feasible when contaminated. Disposable gloves may not be washed or reused. Plastic film food handling gloves are not appropriate for use in exposure-related tasks. If your workers have an allergic sensitivity to certain gloves, OSHA says you must provide hypoallergenic gloves, glove liners, powdered gloves, or other alternatives.
Contaminated means the presence or the reasonably anticipated presence of blood or OPIM on an item or surface. Contaminated items or surfaces can expose workers to blood or OPIM if the contamination is not detected or removed. If a worker has cuts or wounds and a contaminant permeates through the PPE, or if the PPE has even a pinhole, the bloodborne pathogen has a direct path to enter the body. So the goal is to keep contamination levels as low as possible. All equipment and working surfaces must be cleaned and decontaminated after contact with blood or OPIM. You may be able to wipe up a blood spill with toweling, for example, but you still need to render the surface safe. That means a disinfectant is needed to kill bloodborne pathogens. Decontamination is the use of physical or chemical means to remove, inactivate, or destroy bloodborne pathogens on a surface or item to the point where they are no longer capable of transmitting infectious particles, and the surface or item is rendered safe for handling, use, or disposal. OSHA says 4 types of substances are appropriate to decontaminate contaminated surfaces, and we have listed these on the slide for your reference. The standard uses the term regulated waste to refer to the 5 types of waste which require special handling. If your waste does not meet any of these categories, you don't have regulated waste. Some items mention the potential for release, but under no circumstances should waste be squeezed or shaken to determine if it's regulated. And the amount of blood is not a good determining factor because, just as an example, 10 milliliters of blood on a bed sheet would appear as a spot and not be regulated waste, while the same amount on a cotton ball would cause dripping and would be regulated waste. We get questions on bandages, facial tissue, and feminine hygiene products, but in most cases, they would not be considered regulated waste. These are intended to absorb the blood so it's no longer in a liquid or semi-liquid state and would not be released. Contaminated sharps means any contaminated object that can penetrate the skin. If a sharps is not contaminated with blood or OPIM, it's not regulated waste. Box cutter blades that are dull but are not contaminated are not regulated waste. Tricia?
Okay, thank you, Rachel. Okay, so great questions, everybody coming in. Keep them up. I love them. All right. Contaminated sharp containers are made from a variety of products, from cardboard to plastic, and as long as they meet the provisions, OSHA will find them acceptable. Ensure that the sharps container is close to where sharps are used or anticipated. If a worker must travel to a remote location to discard a sharp, it will increase the possibility of an accidental needle stick or improper disposal. So you want them as close as possible to where they're used. Overfilling of sharps containers is a violation. So use a sharps container that has a transparent window, or place the container at a height that allows you to see inside the container. You're not required to provide a sharps container to a worker using lancets or insulin syringes for personal therapeutic reasons. However, you could require that lancet or insulin using workers discard their used lancets and syringes in special sharps containers they bring with them to work. Uncontaminated blades are not regulated waste, but you can place these puncture resistant in a puncture resistant container labeled uncontaminated sharp, and that way no one will get caught. So for all your other regulated waste like contaminated rags and PPE, you'll use a regulated waste container as described on this slide. And disposal of regulated waste must meet applicable regulations of the U.S., states, and territories and political subdivisions. Get this, federal EPA does not have regulations for regulated waste disposal. That's infectious waste, bloodborne, that sort of thing. So you'll need to refer to the environmental regulations of your state or territory. So states and territories may use a different phrase, medical waste, infectious waste, something like that. Now, your waste hauler may also have some suggestions for you. Back to Rachel.
All right, so contaminated laundry. This is laundry which has been soiled with blood or OPIM or may contain sharps. The CPL and interpretations say that clothing manufacturers' instructions should be met and CDC guidelines are available. The CDC guidelines offer 2 choices listed on the slide. Workers may not take contaminated laundry home. It's the employer's responsibility to launder any contaminated laundry or PPE. But you can have a contractor do it. Just make sure the containers of laundry are labeled or color-coded. If uniforms are intended to keep blood or OPIM from passing through to the worker's clothes, undergarments, or skin, or if uniforms are contaminated, then the employer is responsible for laundering it. Now here we depict the universal biohazard symbol legend as it appears in the OSHA regulations, as well as a diagram of the symbol that appeared in the Federal Register back in 1974.
Thank you, Rachel. I love that. Went back to the Federal Register and got that out. All right, a white warning label must be attached to containers of regulated waste, refrigerators and freezers containing blood or OPIM, and other containers that you use to store or ship blood or OPIM. The label has to be fluorescent orange or orange-red in color and have the biohazard symbol followed by the word biohazard in a contrasting color. For contaminated equipment that's ready to be serviced or shipped, you'll attach a label with a statement about which parts of the equipment are contaminated. There are a few exceptions to labeling. They're not required when red bags or red containers are used. Regulated waste that's been decontaminated by incineration, autoclaving, or chemical means prior to disposal is not required to bear the label. Before the waste has been decontaminated, though, it's still regulated waste and must be labeled or color-coded. If universal precautions are used for handling all soiled laundry, the employer may use an alternative color or label for the containers as long as all workers are trained to recognize them. Where there's an overlap between the OSHA and DOT required labels, the DOT label for infectious substances will be considered acceptable on the outside of the transport container, provided that the OSHA mandated biohazard label or red colored coding appears on any internal containers which may be present. Okay, so biohazard signs are required at the entrance to work areas, at HIV and HPV research labs and production facilities per 1910 to 1030. For other workplaces, you'll follow 1910.145 for biological hazard signs, which have a biological hazard warning to signify the actual or potential presence of a biohazard and to identify things that contain or are contaminated with viable hazardous agents. Signs under 1910.145 are only required if failure to designate the hazard may lead to accidental injury to workers or the public, or both, or to property damage. Biological hazard tags identify the actual or potential presence of a biological hazard and things that contain or are contaminated with hazardous biological agents. Tags must be used as a means to prevent injury or illness to workers exposed to biohazards that are out of the ordinary, unexpected, or not readily apparent. But you don't need a tag where signs, guarding, or what OSHA calls other positive means of protection are used. Rachel.
Post-exposure evaluation and follow-up requirements. Now, these only involve workers with occupational exposure, not Good Samaritans. Following a reported exposure incident, you need to make a confidential medical evaluation and follow-up immediately available. An exact time is not given, but OSHA requires this as soon as possible after exposure. If access to care is delayed, it may be a violation. OSHA trainer materials suggest that treatment should begin preferably within 24 hours and no later than 7 days. The exposed employee is the one who suffers the exposure incident. The source individual is an individual, living or dead, whose blood or OPIM may be a source of exposure to the employee. Post-exposure prophylaxis may include not only medications, but also any needed vaccination. You also need to make counseling immediately available to the exposed employee. Counseling concerning infection status, including results of and interpretation of all tests, will help the worker understand the potential risks of infection and make decisions regarding the protection of personal contacts. After the exposed employee evaluation, you'll receive a copy of the healthcare professional's written opinion, which tells you whether vaccination was recommended and provided, and that the worker was told about diseases that result from contact with blood. Any other diagnoses won't go to you. Those are confidential. Be sure you give a copy of the opinion to the exposed employee within 15 days of the evaluation. All the elements listed in paragraph C must be included in an exposure control plan. If a plan element does not apply to you, include it in your plan anyway, but state directly that the element does not apply to your company and explain why. You could keep the plan on paper or electronically, but the CPL says workers must be able to access a copy during the work shift. If a plan is only on computer, it says workers must be trained to operate the computer. A hard copy must be made available within 15 working days of a worker's request. According to the CPL, safer medical devices are generally one of the 3 types as listed here on the slide. Annually, be sure to document in your plan that you've considered any safer medical devices that are appropriate, commercially available, and effective. Another term in the plan requirements is direct patient care involving sharps. Now, for years, this was a gray area, but for the mostly withdrawn regulation at 1910.502, OSHA had defined that as hands-on, face-to-face contact with patients for the purpose of diagnosis, treatment, and monitoring. Contact your OSHA office if you'd like an interpretation as it pertains to your situation. Tricia?
Yep, thank you. So the medical records you'll need are listed here. And for the italicized item, OSHA's looking for documentation showing administrative of the complete 3-dose series. If you cannot get a copy of the vaccination record, OSHA suggests documenting your attempt. And when these records cannot be obtained from the previous employer, you must obtain from the worker a written statement about vaccination status, including the dates, or where that's not possible, the approximate dates of the vaccination. If the employer claims one of the vaccination exemptions, that claim must be documented in the worker's medical record for the vaccination status. And even the declination form is a record of the worker's vaccination status. So keep these medical records for the duration of employment plus 30 years. Training records are not confidential and they're kept for at least 3 years from the training date. Training records may be stored on site where they will be accessible for review. Back to Rachel.
Okay, finally, OSHA calls for a separate sharps injury log if you fall under 29 CFR 1904 record keeping. You can use the OSHA 300 for this as long as you provide the type and brand of the device causing the sharps injury on the log and you maintain your records in a way that segregates sharps injuries from other types of work-related injuries and illnesses or allows sharps injuries to be easily separated. If you're not required to keep records under Part 1904, then you're not required to keep a sharps injury log. Excuse me. Sharps injury logs must be saved for at least 5 years. If this data is shared with other workers or management, you need to withhold the exposed employee's identity and any information that could reasonably be used to identify the exposed employee. Today, we have covered over 70 terms related to the bloodborne pathogens standard. We unmask the regulation one term at a time. Now, before we move on to questions, I'd like to once again thank our webcast sponsor, J.J. Keller Training. Whatever your company's needs, J.J. Keller Training can help with 24/7 access to hundreds of online courses and streaming video training across multiple industries. Today, we're offering our attendees a PDF of our popular Bloodborne Pathogens white paper and access to free Bloodborne Pathogens training in J.J. Keller Training. Use the poll on your screen and we'll be happy to send that out by the end of the week. And now, Kevin, I think we are ready to take some questions here. It looks like we've got a lot of good questions that have come in.
Yes, excellent. Great job, Tricia and Rachel. Thank you for sharing your insights and expertise. Before we do start the Q&A, just want to let everyone know about the evaluation survey we're asking you to complete. That survey will open in a different screen after this webinar. Your input is very important and much appreciated as it helps us to improve our future webcasts. Again, if you'd like to ask a question, just click the Q&A button at the bottom of your screen, type your question, and click the send button to submit. And just be sure, I know some folks might have submitted some questions via the chat, but do want to make sure that you've sent those to the Q&A so we can have the chance to look at them. And once more, if we don't get to your question today, those unanswered questions will be forwarded along to our speakers. So the first question goes to Tricia, and it's pertaining to occupational exposure and is asking, does this include people who have volunteered to be a CPR AED responder and taken that CPR AED training?
Okay, all right. So if they volunteered to be a first aider at your work site, and you then designate them in a sense to handle first aid at your site, or you otherwise expect them de facto to handle that first aid, then they do have occupational exposure. Now, the first aid would involve blood or OPIM. If they're doing first aid that doesn't involve blood or OPIM, that's not covered. But I imagine, you know, if you're designated as first aid, you handle any and all kind of first aid emergencies. So it's very likely that they would have occupational exposure because they're designated to handle possible blood or OPIM related incidents. So I don't know, I hope that helps. Now, merely training, here's an interesting take on that. Yeah, merely training, let's say you train all of your employees in first aid, training doesn't by itself make someone covered under the rule. It's if you designate them for those types of activities that involve blood or OPIM, or you otherwise expect them to handle that. So I hope that, you feel free to train all your employees in first aid, but it's the ones that you designate or expect to handle that will come under the rule.
Okay, thank you. Next question is for Rachel, and it asks, pertaining to the hepatitis B vaccination, is it free for any employee in the program? Meaning, is that across the board?
Yes, OSHA does require that you offer that free of cost to an employee with occupational exposure and anyone who's been involved in had an exposure incident.
Except that, let's say you have a Good Samaritan that had an exposure incident. It's kind of ironic that OSHA would not require you to provide that post-exposure follow-up because Good Samaritans are not covered by the rule. But at the same time, OSHA does highly recommend that you provide that post-exposure follow-up for anyone with an exposure incident, including Good Samaritans. And as part of that follow-up, that healthcare professional may then have them get the vaccination at that time. It's really important to get that vaccination after an incident within some 24 hours for it to be highly effective. Oh, it might drag out to 7 days, but anyway, it's important to get that vaccination after an incident. Yes.
Ready, thank you. Next question asks, what about water treatment plants or sewer plants?
I love this question. I get this question a lot. And I think Kimberly, provided, did mention that there's an OSHA, a letter of interpretation on that. There's probably several actually, and I'm pulling up one right now, dated July 30th, 2007. In fact, if you go search on the words OSHA interpretations, you'll get OSHA's letter of interpretations webpage, and there's a search field. Search on the word sewage, right? That's an uncommon word. You'll probably get some, and sewage and bloodborne pathogen or whatever. This kind of interesting. Sewage, yeah, it has a lot of biological agents in it, raw sewage. And it can have some nasty diseases and whatnot that you can get from that. But ironically, OSHA explains, while recognizing that contact with wastewater and raw sewage poses a number of health hazards, does not generally consider that contact with diluted raw sewage not originating directly from a healthcare facility or other source of bulk blood or OPIM is covered by bloodborne pathogen standard. So it's saying it's probably not covered by the bloodborne standard, but it's some nasty stuff. But then they go on to kind of a disclaimer. They say that, the employer needs to make that determination as to whether the employee has occupational exposure or not. So take a look at the letter of interpretation, see what it says. There may be others too to read. Good question.
Are we required to have a BBP plan at the work site?
Okay, so the written program kicks in when the regulation itself kicks in. So if you have one or more employees with occupational exposure as defined, that reasonably anticipated contact with blood or OPIM is part of their job duties. If you have one or more of those folks, then you need to have that written bloodborne pathogen or exposure control plan is called. Otherwise, you're not required to have that plan, okay?
All righty, thank you. Next one has a hypothetical related to the Good Samaritan. And it says, if an employee renders assistance to another injured employee without any direct assistance from his or her employer, regardless of the industry, including construction sites, are they considered Good Samaritans? And if so, is the employer obligated to this OSHA standard?
Okay, I would direct you to the CPL. We had that on one of our slides, CPL 02-02-069. it's kind of tricky. Yes, you didn't direct anybody to perform first aid, but behind the scenes, between the lines, you might actually expect them to be doing that. So even though you don't designate, if you are expecting certain folks to do that sort of response first aid, then those folks would be covered de facto. But if absolutely none of that is expected, no designation, they're a true Good Samaritan, and we did go over the Good Samaritans a little bit here. If they truly are a Good Samaritan, they are not covered by the standard. I hope it's a little fuzzy when they talk about that expected thing, but I guess you know your workplace and you know whether you do anticipate or expect them to go ahead. Thank you.
Backtracking a little bit to the Hep B vaccine, I have a couple questions just asking, is it good for life, and kind of what more can you share or clarify about the dosages?
Oh, I am not a healthcare professional or CDC expert by any means. I am equipped with the reg, right? The regulation. So I would say at this point, it's our understanding that the CDC does not require a booster for the hepatitis B vaccination. And because the CDC does not require a booster, then OSHA does not require a booster. It's kind of interesting that, children are vaccinated now for hepatitis B. So, folks are getting vaccinated at a very early age. And so we're kind of in this limbo where I imagine CDC is watching to see the effectiveness of this. How long does the hepatitis B vaccination last? At this point, it is declared lifetime, the set of 3 series, but one and done, right? Set of vaccinations. And also, on top of that, it's interesting, a couple years ago, the CDC did update its recommendation for adults age 19 to 59 years old. So now, if you didn't get it as a child, you are recommended to get that as an adult if you've never had the vaccination in your life or never had the actual infection for hepatitis B. And so as folks have this vaccination, based on those recommendations, they're entering the work world, they're employed with a new employer. That employer looks at that and says, oh, you're already vaccinated. That means the employer is off the hook. That's an exception if that employee already had it. So interesting turn of events. Kevin?
Next question asks, we are a distribution company. Do we have to offer the immunization to all employees?
No. The vaccination for hepatitis B is only for those employees with occupational exposure. So you don't need to offer it to all. You can. And if you want to be proactive and do that, if you think that's a good idea, that is your call. By OSHA, though, it's only required for those with occupational exposure. And OSHA does not mention a particular industry in the regulation. It goes by that term, occupational exposure. It could be any industry where you'd have someone with occupational exposure. So you make the determination, see if you have anyone with occupational exposure. Those are the ones that would require that hepatitis B vaccination.
Next question says, we're in the Parks and Rec field, and we ask all employees to go through CPR and first aid training. We don't require office employees to render this as part of their job. So would office employees be considered risk of occupational exposure since we then go through this training?
This is similar to the first question I answered about training. So again, merely training your employees in CPR, first aid does not kick in the standard. It's all about that determination on whether you have someone with occupational exposure. So, and your expectation or designation of those to have those activities with occupational exposure.
All righty, thank you. I think we've got time for one more question. It's for Rachel. It asked, does OSHA exempt small employers for bloodborne pathogen requirements?
No, there really is no number there, but essentially if you are in general industry or shipyard, if you have one employee who has or more employees who have occupational exposure, that means you are covered by the Bloodborne Pathogen standard. So, small employers may have an exemption from keeping an injury and illness record under 1910. I'm sorry, not 1910, 29 CFR 1904. So if that's the case and 1910.1030 applies, then those employers would be exempt from keeping a Sharps injury log, but all other requirements of the Bloodborne Pathogen standard would still apply.
Well, thank you. Unfortunately, we have run out of time today. Sorry that we didn't get to everyone's questions, but again, all of today's unanswered questions will be forwarded along to our speakers. Once again, we hope you take the time to fill out the forthcoming evaluation survey and give us your feedback. And with that, we end today's Safety and Health Magazine webcast. We'd like to thank Tricia Hakovich, Rachel Krupsak, everyone at JJ Keller, and all of you who listened in. Thanks and have a great day.